cardiologist tells you to quit coffee? Your patient asks why, and you realize you actually don't have great evidence. Well, a groundbreaking randomized trial just flipped everything we thought we knew upside down, and it's published in JAMA. Welcome to today's Journal Club, where we're critiquing the DECAF trial and asking, should we finally let our atrial fibrillation patients enjoy their morning cup of joe? We're diving into the DECAF randomized clinical trial, and that stands for Does Eliminating Coffee Avoid Fibrillation? This landmark study was published online in JAMA just this month, challenging decades of conventional wisdom with a provocative finding. Coffee might actually protect against atrial fibrillation recurrence. Let's set the stage. Atrial fibrillation, or AF, impacts 1 in 3 people during their lifetime. It's a massive public health burden. Now, coffee is hands down the most commonly consumed caffeinated beverage in most countries. Patients drink it every single day. Here's the problem. For generations, physicians have routinely advised AF patients to reduce or eliminate coffee. We tell them it's pro-arrhythmic. Patients accept it reluctantly. They Google coffee and heart rhythm, find internet chatter about caffeine triggers, and quit their morning ritual. But there's been a knowledge gap. Despite coffee being ubiquitous and AF being incredibly common, no rigorous randomized trial had ever directly tested whether coffee consumption actually worsens AF recurrence. We had observational studies suggesting coffee was neutral or even protective, but observational studies are notoriously prone to confounding. So the authors asked a simple question: does coffee help, hurt, or do nothing to AF recurrence? This directly challenges conventional wisdom, and the hypothesis was tested in a well-designed randomized framework to finally settle this debate with hard evidence rather than assumption. This was a prospective, open-label, multi-center randomized controlled trial. Patients were enrolled from 5 tertiary hospitals across the United States, Canada, and Australia, giving us an international cohort. The inclusion criteria were rigorous. Adults aged 21 or older with persistent atrial fibrillation or atrial flutter with a history of AF, planned for electrical cardioversion, and crucially, they had to be coffee drinkers, at least 1 cup per day at some point in the past 5 years. The exclusion criteria ruled out patients with adverse reactions to coffee, those unwilling to stick with their assigned group, recent ablation or cardiac surgery, and pregnant women. This was a fairly selective population, and that matters for generalizability, as we'll discuss. Critically, randomization occurred after successful cardioversion. This is important. Some patients fail cardioversion or have immediate recurrence, so the researchers randomized 200 patients only after confirming the procedure worked. The randomization was 1-to-1, stratified by site. In the coffee consumption group, patients were encouraged to drink at least 1 cup of caffeinated coffee or 1 espresso shot daily, maintaining their usual lifestyle consumption. They weren't told to increase coffee, just to keep their normal habits. In the abstinence group, patients were told to completely abstain from caffeinated coffee, decaffeinated coffee, and all other caffeine-containing products. During follow-up, they averaged 0 cups per week. Though notably, only 69% achieved true zero consumption. Everyone was followed for 6 months. Baseline characteristics were well balanced between groups. Mean age was 69 years, 71% were male. Baseline coffee consumption in both groups was about 7 cups per week. About half were already on antiarrhythmic medications. The CHADS VAS stroke risk score averaged about 2.5. At 6 months, the primary outcome was clinically detected atrial fibrillation or atrial flutter lasting 30 seconds or longer, confirmed by physician interpretation of ECGs or device data. Secondary outcomes included clinically detected atrial fibrillation or atrial flutter only, as well as adverse events such as hospitalization and emergency department visits for cardiovascular conditions. And here are the results. Among the coffee consumption group, 47% experienced AF or atrial flutter recurrence. Among the abstinence group, 64% had recurrence. In the primary intention to treat analysis, adjusted for study site, this yielded a hazard ratio of 0.61 with a p-value was 0.01, statistically significant. To translate, coffee consumption was associated with a 39% lower hazard of AF or atrial flutter recurrence. For AF recurrence alone, the secondary outcome showed similar benefit, HR 0.62, P equals 0.01. Atrial flutter alone wasn't statistically significant, but that's because only 6% of participants experienced flutter, underpowered for that analysis. Critically, there were no significant differences in adverse events between groups. Deaths were 0 in both arms. No myocardial infarctions or strokes were significantly different. This wasn't a trade-off study. So what makes this trial strong? First, it's randomized and addresses a major clinical knowledge gap. This is the first RCT of its kind. Randomization minimizes confounding, a major advantage over observational studies. Physicians and patients have been making decisions on very weak evidence, and this provides much better evidence. Second, outcome ascertainment was rigorous. Every AF recurrence required physician confirmation via ECG, wearable monitor, or implantable device. Over 53% of participants had continuous cardiac monitoring. Patients had mean 5.8 clinical visits and 2.1 ECGs during follow-up. This wasn't a study relying on patient recall or symptom reports. Outcomes were objectively documented. Third, the effect size is clinically meaningful. A 39% hazard reduction is comparable to the effectiveness of antiarrhythmic drugs. The sample was powered to detect this size of effect, and results remained consistent in pre-specified sensitivity analyses. This wasn't a one-off finding. But there are important limitations to discuss. First, the trial was open label and not blinded. Participants and physicians knew who was in which group. While AF recurrence had to be confirmed by treating physicians, the lack of blinding could introduce detection bias. Interestingly, more patients in the coffee group had AF detected by wearable monitors, while more in the abstinence group had it detected by standard ECG. This suggests possible differential detection methods that could bias the results. Second, the sample size of 200 is modest. While results are statistically significant, a chance finding remains possible, and adherence in the abstinence group was suboptimal at 69%. If this was an error toward the null, the true benefit might be larger. Third, generalizability is limited. This study only enrolled persistent AF patients undergoing cardioversion. Results may not apply to paroxysmal AF, which is much more common. Also, only 11% of screened patients enrolled. Many were unwilling to abstain from coffee, but notably, many also believed coffee caused their AF. If some individuals truly are coffee triggered, and this subpopulation was excluded, then the trial may not reflect their experience. Finally, baseline characteristics had some numerical imbalances: sex, prior ablation, coronary disease. Sensitivity analyses adjusting for these showed similar results, which is reassuring, but the possibility of residual confounding can't be excluded. So what does this mean clinically? This is a paradigm shift. We've been advising AF patients to reduce or eliminate coffee based on weak evidence and conventional wisdom. This RCT suggests that moderate coffee consumption, about 1 cup per day, may actually reduce AF recurrence after cardioversion. The clinical implications are substantial. For coffee-drinking patients with persistent AF who undergo cardioversion, continuing moderate coffee consumption appears safe and potentially beneficial. This should change our counseling, but important caveats exist. These findings don't apply to high-dose caffeine or synthetic products like energy drinks. They don't yet apply to paroxysmal AF, which needs further study. And for individual patients who genuinely feel coffee triggers their episodes, this shouldn't override their experience. Here's the bottom line. In coffee-drinking patients with persistent atrial fibrillation, undergoing cardioversion, moderate caffeinated coffee consumption is associated with a 39% lower risk of AF or atrial flutter recurrence compared to abstinence, challenging decades of clinical advice and suggesting that coffee, in moderation, may be both safe and potentially protective. What do you think? Will this change how you counsel your AF patients? Do you see barriers to implementing this in practice? Drop your thoughts in the comments below. Subscribe for more evidence-based journal club critiques, and thanks for watching.